Good morning, guys, or good afternoon. Depends on the time at your place. So, can you hear me well? Can you see me as well? Yeah, good morning, Dr. Kanik. Dr. Shard, how are you all, guys? So, is everything okay? Good morning, Doctor. Good morning, Dr. Melissa. Yeah, okay. So, I'm great. Thank you for asking. So, yeah, welcome to our webinar. This is your host, Dr. Amr. But let's wait a minute so also the people can join and then we can start. Okay, guys, so let's start our webinar first. I want to welcome you guys. And I'd like to introduce myself at first. My name is Dr. Amr Zayed. I am an IMG doctor. I passed step one with nbme scores all above 80s. My highest one was 87. And I am one of the tutors here with the Match Guy, and I'm really glad to have you all here. So, if this is the first time you are attending one of our webinars, the idea of our webinars is that it's a weekly session in which we discuss like a changing topic every week. And of course, the topic is so much important, is high yield. So if you feel like that you already know about that topic, you can use this as a chance to practice and to test your knowledge. And if this topic is confusing you, this will be your perfect chance to master it. Good morning, Dr. Sumaya. How are you guys? Okay, so yeah, first of all, and our topic today, guys, is a very, very interesting topic, which is the nephritic and nephrotic syndrome. So first of all, I want to share my screen and I want you to tell me, guys, if everything is okay and you can see my screen. So yeah, is everything clear, guys? Yeah, okay. So yeah, our topic today will be about the nephritic and nephrotic syndrome. I actually believe that this topic is one of the most, I wouldn't say it's a confusing, but I would say that many of you guys like consider it at one of the most challenging topics in the renal system. We will today we'll break it down together. We will see how to approach it, how to differentiate between the different causes, and also at the last of this session we will do some practice question from our amazing QBank to also apply and practice this topic. But I don't want let's have a deal, guys. I don't want this session to be like a lecture. I am just talking and you are listening. I want it to be as interactive as possible. I want you always to type in the chat what do you think, to answer my questions if I'm asking about something, to add any information that you think that it's valuable. So I want this to be back and forth between me and you guys. I don't want it to be me just talking and explaining stuff, because the idea of this whole thing is interacting with each other and enjoying this topic together. So bring your notes, be very focused, and so let's start. Okay, guys. So first of all, I always approach this topic in three manners. The first thing that we first need to understand if it's nephritic or nephrotic, like to assess the symptoms of the case to understand if it's nephritic or nephrotic. And after doing that, we will diagnose the cause according to the risk factors or the association with it. Great, great. And after that, we will know every important thing about every cause, because that will what the question will be asking most of the time. So the first thing we will approach it like we will decide if it's nephritic or nephrotic. So if it's nephritic, we have some causes and we will differentiate between them. And if it's nephrotic, we will have some causes and we'll differentiate between them. So first of all, what is nephritic, guys? So itic, like this ITIC, this means inflammation. So this is inflammation of the glomeruli of the kidney. So this inflammation led to like leakage of a large amount of RBCs and also a mild amount of protein. Great, great. So how will this present in our case? Those leakage of RBCs will present with hematuria, of course, and dysmorphic RBCs or RBCs casts or something called, or a description called tea-colored urine. So the first thing that we will notice in the nephritic syndrome is that we will have hematuria, aka RBCs casts in the urine, aka tea-colored urine, etc. Whether the way they describe it, but it will mean that there is blood in the urine. And also we will have like leakage of a mild amount of protein, so we can also have mild edema, because some of you guys think that edema is just exclusive to the nephrotic syndrome. No, also we can have mild edema in nephritic, and I will tell you why. Also, this is inflammation, so this means that the kidney is damaged, the glomeruli is damaged, so we will have decreased the glomerular filtration rate of the kidney, which will increase the renin-angiotensin system, and we will have symptoms of of kidney injury like oliguria, hypertension, edema, as we said, or the mild edema, as we said. We can also have electrolyte disturbance and acid disturbance. So what we will find mainly on the nephritic syndrome, the case will be presenting with a patient with tea-colored urine, RBCs cast in the urine, or hematuria, and also we can have mild edema, and you can see signs of the kidney injury, whether it's oliguria, whether it's hypertension, like you can see some mild electrolyte disturbance, depending on the level we are, and you can also see some acid disturbance, but the most thing that you will encounter is the hematuria or the tea-colored urine. So this is nephritic syndrome, okay? What about nephrotic syndrome, guys? So nephrotic syndrome is mainly due to increase the permeability of the basement, or increase the permeability of the basement membrane to plasma proteins. So we have something that caused the membrane of the renal to be more permeable to plasma proteins. So this will lead to something called proteinuria. And we can diagnose it whether by +4 on the dipstick or more than 3.5 grams per day. So that this is the nephrotic range of proteinuria. Okay, this is just talking, but how it will present in our case, like how I can say that this case is nephrotic syndrome. So we have proteinuria, guys. So we will lose albumin in the urine, because albumin is a protein, and this albumin in the urine will cause foamy or frothy urine. Unlike the tea-colored urine in the nephritic, we have here foamy or frothy urine, and also the loss of albumin and the loss of the protein in the urine will decrease the oncotic pressure of the plasma, so it will lead also to generalized edema. So here the edema is generalized and it will be so predominant. Unlike the edema in the nephritic, it will be mild, and the predominant symptoms will be the tea-colored urine or the RBCs. So we have generalized edema and foamy and frothy urine. What else we will lose in the urine? We will lose the immunoglobulins, because immunoglobulins, guys, is also a type of proteins. So this will lead to recurrent infections. So this will be our third symptom. And also we have many proteins or many carriers in our body, which are formed also as well of proteins. So we have the transferrin, the vitamin D binding protein, and there is one important protein related to it's an anticoagulant. Can anyone tell me what was this protein? As I said, I want it to be interactive. Exactly, Dr. Sumaya. It's the antithrombin, and this is the most important one here. The antithrombin 3, exactly. So loss of this antithrombin in the urine will lead to hypercoagulability. Great, great. So this is our set. And one final thing is that we have loss of protein in the urine. So the protein will be decreased in our blood. So the liver will try to synthesize more albumin. So we'll try to synthesize albumin. And this is associated with also increased the synthesis of the lipoproteins. They are associated with each other. So while the liver was trying to synthesize albumin, he also synthesized lipoproteins that will lead to hyperlipidemia and hypercholesterolemia. hypercholesterolemia. So this will be our final symptom. So in nephrotic syndrome, we will have the foamy frothy urine, the generalized edema or the periorbital edema, or it will be edema with high level to the abdomen or something. We will have a patient with recurrent infection due to the loss of the immunoglobulins. Also, we will have a patient with hypercoagulability and hyperlipidemia, hypercholesterolemia. This also can appear in the urine, something called fatty casts, because the hyperlipidemia and the hypercholesterolemia and the lipids and the cholesterol are fats, so it can cause fatty casts in the urine. So tea-colored urine in a patient with decreased kidney functions like oliguria, hypertension, this is nephritic syndrome. While if we have a foamy frothy urine, generalized edema, hypercoagulability, hyperlipidemia, hypercholesterolemia, this is the nephrotic syndrome. So at this point, are we clear, guys? Great. So this will be the first thing I'm looking at the question. I will decide whether it's nephritic or nephrotic according to the symptoms in the question. Okay. Let's say that we find a patient that with hematuria and hypertension and electrolyte disturbance. So I decided that this is nephritic. How I approach the nephritic syndrome. So nephritic syndrome, guys, will present with three presentations. Okay. The first one will be a patient with recent infection. And this will lead me to two diseases. Can anyone tell me what are those two? Exactly, the acute post-streptococcal glomerulonephritis, and the second one is the IgA nephropathy, and we will differentiate between them right now. So this will be the first presentation. It will tell you like the patient just recovered from a recent infection, whether it's days ago, whether it's weeks ago, and we will see the details about this. The second thing, like it will be a patient with extra renal symptoms. I will find symptoms outside the renal. So this will lead me to two syndromes. Can anyone tell me those two syndromes? Exactly. The Alport. Good job, Dr. Hardik. Good job, Dr. Sumaya. No, Dr. Sumaya, it's not the rapidly progressive. We will talk about the rapidly progressive, but the extrarenal symptoms, I mean like in other systems like the lung, the eye, the ear. So it's the Alport syndrome and the good posture syndrome. And finally, we will have a patient with history of systemic lupus or the SLE, like symptoms of systemic lupus, like the malar rash, the arthritis, the thrombocytopenia. So this will be okay. It's the membranous proliferative and the diffuse proliferative. So it will be the diffuse proliferative glomerulonephritis. The thing about membranous proliferative, the diffuse proliferative is like exclusive to the nephritic syndrome. But the membranous proliferative, it can present with the two syndromes. It can be nephritic and nephrotic, but most commonly you will find it in presenting with nephrotic symptoms. So we will talk about it in the nephrotic. Here we are talking about the diffuse proliferative because it's also had another name, guys. Can you tell me that name? Like it has another name, aka lupus nephritis. Okay, so this is our set. So if we have a patient, this is a great Dr. Nia. Yeah. So if we have a patient with recent infection, I will think about two: the acute post-streptococcal glomerulonephritis and the IgA nephropathy. If I have a patient with extrarenal symptoms, for example, if he has eye problem, vision problem, lung problem, so I will be thinking about the Alport and the Goodbuster syndrome. And if I have a patient of course, with nephritic syndrome and symptoms of systemic lupus, then I will be thinking about the diffuse proliferative glomerulonephritis. Now, let's talk about each two of those. So, first of all, what we need to identify about every pair of those, that like what are the risk factors, like what will be in the history, so that I say, yeah, that is whether it's IgA nephropathy or the post-streptococcus. And after we determine that, also we will need to talk about the histology aspect of it. We won't talk about because we have the light microscopy and the electron microscopy and the immunofluorescence. We won't talk about all like the three in all types. We'll just pick what's important in every type so that we don't overwhelm ourselves with low yield stuff. We'll just talk about the high yield stuff in the histology aspect. But first of all, let's differentiate between post-streptococcus glomerulonephritis and IgA nephropathy. So the post-streptococcus glomerulonephritis will present, most of the time it will be a child that had a strep infections. Like he got a strep infection, whether it's a throat infection or a skin infection. And the skin infection, it presents like something called impetigo. Great, Dr. Hardik. Yeah, so we will have this in the history. It's whether strep infection is a sore throat and the other stuff, or it can be a skin uh, infection. Okay, so great. The second thing and the most important thing, that the latent period will be, yeah, exactly. It will be long. It will be 2 to 3 weeks. So here we have a bit long latent period, and also the complement level, or there will be an activation for the complement system. So we will have decreased C3. While in the other side, the IgA nephropathy, it also happens in the child, but it will be most of the time older childs. It can be also in the young. And here also we can have history of mucosal infection, because as we know, IgA present in the mucosa. And the latent period here in the IgA nephropathy is days, exactly. So it can happen in the same days. It can happen concurrently with the infection, or after it 2-3 days. So you remember it like the post-streptococcal glomerulonephritis. It's a very, very long name, like post-streptococcal glomerulonephritis, while IgA nephropathy is just IgA nephropathy. So the long one will be 2-3 weeks, and the short one will be 2-3 days. And also the C3 will be normal. That also is a very, very important differentiation between the two. And also there's a detail about the IgA nephropathy. It will present in a recurrence state. Like you'll find in the case that he got hematuria like multiple time a year and then resolved and it came again. So if you saw this recurrence pattern, this also will lead you to the IgA nephropathy. Okay, so that's like the general overview between the two. Now let's talk about the details of every one. Okay, so first let's talk about we have the electron microscopy, the light microscopy, but let me here add the light microscopy because it's also important in the. So can anyone tell me the light microscopy of the post-streptococcal glomerulonephritis, what we will see? Hmm. The subepithelial is in the electron microscopy, but the light microscopy will be hypercellular glomeruli. So we have hypercellular glomeruli due to the inflammation and stuff. And the electron microscopy, which most of you said, will be the subepithelial humps. Exactly. It will be, let's say that this is the epithelial of the podocytes, so it will be like subepithelial, so it will be like a bit like the hump. And finally, the immunofluorescence will be exactly the starry sky, or the lumpy, bumpy. You can just like remember those phrases, or like the general one is the granular appearance. So in the immunofluorescence, guys, we have two things, something called whether granular or linear. Okay, so let's have a look here. Okay, so it could be granular or linear. So the granular, it will be most of the time due to type 3 hypersensitivity. There is immune complex that will deposit on the granular. So it will deposit in random way. So we'll find the green fluorescence, like there will be gaps in the middle, and it isn't organized. While the linear, it is due to type 2 hypersensitivity, like when there is antibodies attacking the basement membrane. So the antibodies will just attack every single bit of the basement membrane, exactly as in Goodbuster syndrome, and we'll discuss it. So it will be just like this. It will be organized. It will be covering everything of the glomeruli. So that's called linear. we just only have the Goodbuster syndrome. It's the only type 2 hypersensitivity, and most of the causes are type 3, so the other all will be granular. And we will just talk about this when we come to it. Okay, that's about the post-tuberculosis. Now let's talk about the IgA nephropathy. What's important in the IgA nephropathy is the immunofluorescence, which is, or the light microscopy. They all, I think, they share the same description, which is exactly the IgA deposits complexes in the mesangium. This is very, very important keyword, and it is very, very important, and sometime it will be your answer in the exam. So the IgA deposit in the mesangium, okay, or the mesangium hyperproliferation. Great. Also, we will find this IgA nephropathy. It can be associated uh, with a famous disease, which is called, or a famous syndrome, exactly the Henoch. I don't know if I am pronouncing it right or wrong, but I think it's the Henoch Schönlein purpura. So the Henoch Schönlein purpura is also due to IgA deposition in the GAS. The G is the GIT, so it will cause abdominal pain. The A is so it will cause arthralgia, it will precipitate in the joint, and the S, which will be the skin, causing the purpura, hence why it's called the Henoch-Schönlein purpura. And if it's also deposited in the kidney, it will cause the IgA nephropathy. So I have a patient with a history of streptococcus infection with a latent period, and he has hematuria. This is acute post-streptococcal glomerulonephritis. It will appear like with subepithelial humps in the electron microscopy and granular in the immunofluorescence. While if I have a child with a concurrent infection and he has nephrotic syndrome or signs of nephrotic syndrome, so this will be IgA nephropathy due to IgA deposition in the mesangium that led to the nephritic syndrome. Okay, now let's talk about the two syndromes. As we said, now I have a nephritic syndrome plus extra renal symptom. So if this symptom is hemoptysis, like coughing of blood, this will be the Goodbuster syndrome. If we have ear affection and eye affection, so if we have a vision problem, hearing problem, this is the Alport syndrome. Now let's discuss what happens in everyone. So the Alport syndrome is due to mutation 2, 3, and 4. So 3 is the alpha 3 chains, and 4 is, so it's mutation to alpha 3 chains of type 4 collagen. Okay, so you can remember it, 3, 4, mutation to the alpha 3 chains in type 4 collagen. It is also X-linked dominant, but I don't think it is that important. So this mutation will affect not only the renal, it will affect the renal, which is the glomerular basement membrane, the eye, and the ear. So since we have the mnemonic can't be and can't see, and finally can't hear a B. Great, Dr. Sumay. Yeah, so this, and I want to think of you to think about it like the Alport syndrome is a mutation. The mutation will affect many parts of the body, so that's why we have the eye and ear problem. Also, we have the EM of it, how it will appear. It's not that high yield, but it's something called basket weave pattern because it led to splitting of the glomerular basement membrane. Now let's see the Goodbuster syndrome. It's pretty much similar mechanism, but here it's not mutation on alpha 3 of the type 4. It's antibodies directed against the alpha 3 of type 4. Exactly. So it's antibodies. So we have 2, 3, 4. 2, so it's type 2 hypersensitivities. It's antibody directed against something. Directed against what? Alpha 3 chains of type 4 collagen. So this will attack the basement membrane in the renal or in the glomeruli, causing hematuria. And also it will attack in the lung or the alveolar basement membrane, causing hemoptysis. Exactly. So if I have a nephritic syndrome with hemoptysis, I am at Goodpasture syndrome. If I have a nephritic syndrome with hearing problem and eye problem, I am at the Alport syndrome. Great. Finally, let's move to the last one, which is the diffuse proliferative glomerulonephritis. As we said, it's associated with a patient with history of systemic lupus erythematosus. So you'll find the symptoms like the mallow rash, the arthritis, the thrombocytopenia, etc. So nephritic syndrome plus symptoms of systemic lupus, I am thinking about the diffuse proliferative glomerulonephritis. What I need to know is the LM. It is very, very characteristic of it, which is exactly the thickened wired loops. So this is very, very important. And on the EM, I want just to put this at the back of your mind. It causes something called subendothelial, endothelial, not epithelial, subendothelial deposits. Yeah. So just like put this at the back of your mind. You might see it here or there. So I just want you to be aware of it. But most of the time, the case will be clear. It won't depend on that information 100%. Okay. Okay. So and the immunofluorescence of it will be granular because it's type 3 hypersensitivity. As I said, most of the nephritic syndrome are all granular except the Goodpasture syndrome because it's type 2 hypersensitivity, so it will cause the linear deposition. Okay, guys, so now we talked about like 5 types. I want now you to know that these 5 types, like the diffuse proliferative glomerulonephritis, the Goodpasture and the Alport, the post-streptococcal glomerulonephritis, they all can lead to rapidly progressive glomerulonephritis. So rapidly progressive glomerulonephritis, it is not a disease itself, but it's like an end-stage nephritic syndrome, like when the nephritic syndrome progressed too much, whether the cause of it will lead to rapidly progressive glomerulonephritis. So we classified that rapidly progressive glomerulonephritis according to the mechanism on 3 types. Type 1, which is due to antibody against basement membrane, and this is which type? Which exactly the good pasture, and how it will present under the immunofluorescence, granular or linear? Exactly, linear. While the type 2 is antigen-antibody complex, and this is pretty much the rest, which is the acute post-streptococcal, the IgA, the DBGN. So this all go under this type. So, and the immunofluorescence will be the immunofluorescence, granular or linear? Exactly, it will be granular. And finally, we can't like if we looked under the immunofluorescence, we didn't find any deposition, which is something called the low or the post-immune, and this is due to small vessel vasculitis. Most importantly, the Wegener and the microscopic polyangiitis. The Wegener was associated with which type of anti-nuclear cytoplasmic antibody? Exactly the C ANCA, and the microscopic polyangiitis was with the P ANCA. So this is due to something related to the the white blood cells and etc. So it's not something immune. So we won't find anything under the immunofluorescence. So no deposition. Okay, so this, like, I want to understand this type, like the rapidly progressive glomerulonephritis. It's not a disease itself, whether like it's a description of what happened if the nephritic syndrome progressed to an end stage. Whether was its cause, like if it was IgA nephropathy, if it was post-streptococcal, if it was Goodpasture, they all can progress to the rapidly progressive glomerulonephritis, and how it will present. So, as we said, there will be like extensive inflammation, which it will start to leak a macrophage, monocytes, fibroblast, fibrin. So it will just deposit in the glomeruli, the fibrin, and collagen will deposit, and it will cause something called the crescent shape under the light microscopy. So if I found a patient with nephritic syndrome and there is the fibrin and the collagen deposition in the glomeruli or the crescent shape, so that means that I had a nephritic syndrome or a cause of the nephritic syndrome that progressed to something called rapidly progressive glomerulonephritis. And we talked about the different types of it. So a quick overview of what we said to this point. So at first, I have a patient with nephritic syndrome. How I know that it's nephritic syndrome? It will present with tea-colored urine, hematuria, RBCs in the urine, etc. And I'll find the kidney function is decreased a bit. So I am nephritic syndrome. Now I am thinking about the cause. If the presentation, a patient with infection, so I am either acute post-streptococcal or the IgA nephropathy. How will I differentiate between the two? With the latent period and the complement system. In post-streptococcal, there will be long latent period, 2 to 3 weeks, and we will have decreased C3. While in IgA nephropathy, the C3 will be normal and the latent period will be 2 to 3 days. What is important about the post-streptococcal? The subepithelial humps and the starry sky granular appearance. What is important in the IgA nephropathy is the IgA deposit in the mesangium. Great, great. What if I have an extrarenal symptom? If it's hemoptysis, it's the Goodpasture syndrome. It's due to antibodies, type 2 hypersensitivities against the alpha-3 chains of type 4 collagen 2, 3, 4. While if it's hearing problem or vision problem, it will be the Alport syndrome, which is mutation to the same thing, the alpha-3 chains of type 4 collagen, and it will have the basket weave pattern. What if the patient had a history of systemic lupus? So this is the diffuse proliferative glomerulonephritis, and I will have the thickened wire loops under the light microscopy. Okay, this all can progress to rapidly progressive glomerulonephritis, in which there is collagen and fibrin deposition in the glomeruli, causing that crescent shape. And we, as we said, we classified the types. So if it's antibody against basement, this is type 1, the Goodpasture. If it's type 2, the complex, so this is pretty much all the other types. And it could be due to no immune at all, the low or the pussy immune. So it will be due to small vessel vasculitis, the Wegener, and the microscopic polyangiitis. So this is pretty much everything that we need to know about the nephritic syndrome and its causes. Okay? Okay. So now let's say that we had a nephrotic. Okay, Doctor, what's the relation between the AKI and the nephritic syndrome? Yeah, nephritic syndrome, as you said, like the nephritic syndrome could sometime progress, which will lead to decrease the GFR, and it pretty much cause the symptoms of the acute kidney injury. And also, you will find these symptoms if those things progress to the rapidly progressive glomerulonephritis, you will find the symptoms of acute kidney injury. So that's why at the start I said, sometimes with the nephritic syndrome, don't just depend on the hematuria. You could also sometimes find the symptoms of decreased renal function or the acute kidney injury, which is the oliguria, the hypertension, the electrolyte disturbance, acid disturbance. So yeah, they pretty much can happen with each other. Exactly that the nephritic may cause the because it's inflammation and damage to the glomeruli. So at certain point it will cause injury that lead to acute kidney injury. Okay? Okay. So are you ready to dive into the nephrotic syndrome, guys? Is the previous part all clear? Great, great. And don't worry, we will solve some question at the end of the session also to make sure that I want to make sure that you understand everything pretty much. Okay. Now let's say that our case was a patient with a foamy frothy urine, generalized edema. He has history of recurrent infection, or he is in hypercoagulable state. He has hyperlipidemia, hypercholesterolemia. So now I diagnosed my patient to nephrotic syndrome. What is the next step? Okay, so let me go to nephrotic syndrome. Okay, so let's divide nephrotic syndrome to pairs so that we can understand it better and compare each pair with each other. So instead of 6 things, we will have 3 things. Our first pair will be the minimal change disease and the focal segmental glomerulosclerosis. So we have the minimal and the focal. This is our first pair. Our second pair will be the 2M, the membranous nephropathy and the membranoproliferative glomerulonephritis. And as I said, the membranoproliferative glomerulonephritis, it can either present with nephritic or nephrotic because it starts with nephritic and then progress to nephrotic. But for me personally, most of the time that I encounter it was with the presentation of the nephrotic. So let's just put it here. But I want you to keep that in mind so that if you find it presenting with nephritic or something, you don't be confused. And finally, we have 2 systemic disease, the amyloidosis and the diabetes mellitus. Okay, so now we have 3 pairs, and we will talk about every pair with each other. So let's start with our first pair, which is the minimal change disease. How it will present. So the minimal change disease, I see that most of you like agreed on something that it happened in children. So it's called minimal change disease. So it doesn't affect the kidney that much. So it will just be children plus nephrotic syndrome. So if you find a children with nephrotic syndrome, just nephrotic syndrome, nothing else. So most of the time you want to go to the you want to think about the minimal change disease. But like how it happens or what is the pathophysiology of it. So let's say that there is we have a children. It can happen to either two causes. The first cause is which is primary cause. So let's say the children have recurrent infection, recent immunization, he got recently immunized, or atopy, allergy, bee sting, like in general something that stimulated the immune system. Okay, and it could happen secondary to, as Dr. Sumaya said, Hodgkin lymphoma. It's like a bit vague, but just remember it. Exactly. So if we have something that stimulated the immune system or the Hodgkin lymphoma, this leads to overproduction of cytokines. These cytokines will attack the food processes of the podocytes, leading to damaged podocytes and fusion also, and flattened and effacement podocytes, and most importantly, loss of the negative charge or the anion. Okay? Okay. So this here is the pathophysiology of the three. There is something that stimulated the immune system, so it attacked and damaged the podocytes and flattened and effacement in the food processes and loss of the negative charge. So the negative charge, guys, is the thing that like block the albumin from leaking. So if we have if this negative charge is lost, the albumin will leak. So that's why it's just like a child with nephrotic syndrome. It will be a child with edema, periorbital edema, or stuff, and it will be just it. So I want you to think about the minimal change disease. Okay, what we will see in the light microscopy, guys? Tell me. Exactly, and that is a very very important thing to know. The light microscopy, it's normal because it's minimal change disease, so there is minimal change. But if we zoomed in with the electron microscopy, what we will see exactly the effacement and uh, the diffuse effacement of the podocytes food processes. Okay, so that's is the minimal change disease, and actually it have a good prognosis and it respond to steroids. Exactly, it's respond to steroids. You are brilliant, guys. Okay, what about the focal segmental glomerulosclerosis? It will be in an adult. It's not that much high yield topic, but just let have the most important thing about it or how it will present. It will be an adult with the two H, HIV or AIDS, and the or he is injecting heroin, and also as Dr. David said in sickle cell disease and as well obesity. So just an adult with HIV or obese or have a history of sickle cell disease or heroin use. So I'm thinking about the focal segmental glomerular sclerosis. Great, great. The LM and the EM is not that much important, but the LM from its name, as Dr. Sumaya said, sorry, it's also in the it's important. It's like present in African American people. Brilliant, Dr. Sumaya. So it's always in the black people or the African American people. Okay, so the LM and the EM, it's not that important, but from its name, it's called focal segmental glomerular sclerosis. So there will be segmental, sorry, there will be segmental glomerular sclerosis from its name. And the EM, it will be the same like the minimal change disease. There will be effacement of the podocytes. Great, great. So, and this is bad, this have bad prognosis and doesn't respond good to steroids. So I have nephrotic syndrome. If I am a child, just a child with nephrotic syndrome, or there is a history of recent infection or atopy or allergy or Hodgkin lymphoma, so this is minimally changed disease. Why it happens? It's due to effacement of the podocyte food processes, which will lead to the loss of the negative charge, and that will lead to leakage of the protein that caused the nephrotic syndrome. In the LM, it will be normal, nothing, it's minimal, but if we zoomed in with the electron microscopy, we will find the pathology, which is the effacement of the podocytes food process. While if we have an adult with history of heroin abuse or HIV or AIDS or sickle cell disease, African American. So this is the, with nephrotic syndrome, of course. So this is the focal segmental glomerulosclerosis, and it will appear as segmental glomerulosclerosis in the light microscope. Let's go to the second pair, and this is the most important pair because this like repeat much at the exam. The first one, which is the membranous nephropathy. So first of all, like, what is the pathophysiology of the membranous nephropathy, or what happens in the membranous nephropathy? In membranous nephropathy, guys, we have increased IgG, okay? So this IgG will attack the phospholipase A2 receptor. Exactly, as phospholipase A2 receptor. And this receptor is presents on the podocytes, and that's why we got the pathology of the nephrotic syndrome due to the same mechanism. So why this happened, guys? So it could be primary, which is just idiopathic. We don't know the reason. Or it could be secondary, and this is very, very important. I want you to tell me, guys, the causes, because every cause is important. So the first cause is drugs. Which drugs specifically, guys? Okay, first of all, okay, so we have this SLE. Great. So SLE or hepatitis B or C. Also, we have solid tumor. And finally, we have the two drugs, which is the NSAIDs and the penicillamine. Okay, so if I have a nephritic syndrome with SLE, it will be nephritic. It will be exactly, and syphilis. Okay, nephritic with SLE, it will be diffuse. Great, but what about nephrotic with SLE? It will be the membranous nephropathy. Okay, what if I have a history of hepatitis B and nephrotic syndrome? It will be membranous nephropathy. What if I have nephrotic syndrome and a solid tumor? It will be membranous nephropathy. Okay, I want you to tell me, guys, also, like this, the penicillamine, it was used for something which is Wilson, exactly. So if I have a patient with Wilson disease that got treated with a drug, and then he like present with the symptoms of nephrotic syndrome, so this also is membranous nephropathy. Great. Now let's talk about the EM, and it is very, very important, which will be hmm, spike and dome appearance. Exactly, Dr. Sumaya. So it will present something called spike dome appearance. And the light microscopy, we will just find it's called membranous nephropathy, so it will be just columnar basement membrane thickening. Okay, so if I have a patient with one of those risk factors, of course, with nephrotic syndrome, SLE, hepatitis B, solid tumor, NSAIDs, penicillamine, so it's membranous nephropathy. What about the membranoproliferative glomerulonephritis? As I said, this one is like a bit tricky. It can present with nephritic or nephrotic, but I assure you won't see it that much in your exam. But just we need to know about it that it can be associated with hepatitis C. It's very, very important. And also it deposit inside the basement membrane itself, causing something called tram truck appearance. Exactly, tram truck appearance. Great. So a patient with hepatitis C, nephrotic syndrome, a tram truck appearance on the basement membrane. So this is membranoproliferative glomerulonephritis. But now let's, guys, so I did this. I am not that good at drawing, but I tried to make it simple as possible. So let's say that this is, yeah, exactly. Also, the C3 nephritic factor as well is associated with it. But let's say that this is the epithelial podocytes, and this is the basement membrane, and this is the endothelium. So as you said, we have the sub-epithelial humps. So the sub-epithelial humps, which was due to the acute post-streptococcal glomerulonephritis. So the subepithelial humps, exact. But what if we have the subepithelial deposits and also thickened basement membrane, which is something called the spike and the dome appearance? So this will be the membranous, exactly. What if we have it is inside the basement membrane, deposit inside the basement membrane, leading to its splitting and causing the tram track appearance? This will be the membranoproliferative glomerulonephritis, and we can have also the subendothelial as well. As we said, it could be in the diffuse proliferative glomerulonephritis, but this is not that much characteristic about it. So we have one from nephritic and two from nephrotic. The one from nephritic was the subepithelial humps of the acute post-septic glomerulonephritis. The two from nephrotic was the subepithelial deposits plus the second basement membrane, aka the spike dome appearance. So this is the membranous nephropathy, and the tram track appearance inside the basement membrane itself due to its splitting. So this is the membranoproliferative glomerulonephritis. Great. Now finally, let's talk about the two systems. As we said, we have the focal, segmental, and the minimal change. We have the 2M, the membranous, and the membranoproliferative, and we have two systems, which is amyloid and DM. So in amyloidosis, guys, the kidney is the first organ to be affected in systemic amyloidosis. Whether it's like due to the multiple myeloma and the immune light chains, whether it's due to chronic inflammation that increase the serum amyloid A, like in summary, we have systemic amyloidosis, and whether it's a cause, we have many causes. We have like 3 4 causes of amyloidosis, the hemodialysis as well. So and this amyloid will deposit in the kidney, and it is stained with a specific stain. Can anyone tell me the stain? Exactly, the Congo red stain. It will show the amyloid as a pink amyloid, and it will appear under polarized light as exactly the green apple. So the apple green birefringence. Okay, so a patient with nephrotic syndrome, history of amyloidosis. So we have amyloid nephropathy. It is stained with the congruent stain. It like a pink amyloid, or under the polarized light, it will be the apple green birefringence. What about the other system, which is diabetes mellitus? I tried here to sum up the pathophysiology, like the most easiest way. So if guys, first of all, we have diabetes mellitus. So there's something called non-enzymatic glycation of the proteins. So we have non-enzymatic. This is one of the mechanisms of like the effects of increased the amount of glucose in blood. So we have non-enzymatic glycation of the protein, which will lead to hyaline deposition. Okay, so don't mind this. We have the non-enzymatic glycation of the basement, the proteins, so it will lead to hyaline deposition. This hyaline deposition will cause thickening and narrowing of the blood vessel because it will deposit in the blood vessel, so it will cause a thickening and narrowing. And that will lead to, if the blood vessel is large or medium sized, so it will lead to something called macroangiopathy, which will predispose to atherosclerosis and cause the things that we know, the angina, the myocardial infarction, the ischemic stroke, all the things of diabetes, the diabetes complication. But if this blood vessel is small size blood vessel, so it will cause something called microangiopathy, not macro. So something called hyaline arteriosclerosis. And we have the triad, the neuropathy, retinopathy, and nephropathy. And here we are talking about the nephropathy. So, like, did you understand how we reach it? So, first of all, we have non-enzymatic glycation of the blood vessel, which will lead to hyaline deposition. Hyaline deposition will deposit in the blood vessels. If it's the large and the medium blood vessels, it will cause the major complication of diabetes, which is the angina, the MI, the ischemic stroke, etc. If it's in the small blood vessel, the microangiopathy, the hyaline arteriosclerosis, it will cause the triad of neuropathy, retinopathy, and nephropathy. And here we are talking about the nephropathy glomerulosclerosis. So as we said, there is hyaline deposition that's called thickening and narrowing of blood vessels. And in our case, in the renal system, it will deposit in the afferent and efferent. Okay, we'll come to the chemistry Wilson nodules. It's deposit in the afferent and the efferent. So, like there will be less blood going to the kidney due to the because there will be thickening here. So this is will decrease the GFR, which will stimulate the renal angiotensin system, which will lead to vasoconstriction of the efferent. So the vasoconstriction of the efferent and as well the deposition will lead, so this efferent will be very, very narrow. So that will increase the hydrostatic pressure that back on the kidney and increase the GFR, cause something called hyperinfiltrate injury. I just like want you to understand the pathophysiology for one time, and then we will focus on the high yield. So we have hydrostatic pressure increased due to the vasoconstriction and the deposition of the hyaline deposition, and we have increased GFR that will lead something to called hyperinfiltrate injury. And as you said, guys, this increased hydrostatic pressure when it go back to the glomeruli, it will lead to something called nodular glomerulosclerosis, which is the Wilson nodules, exactly as you said, guys. So this is stained. This nodules is stained positive with the pass stain and eosinophilic with the H and E. So the two systems have two stains. As we said, the congruid was in the amyloid, and we have the pass stain in the diabetes to stain the Kimmelstein-Wilson nodules. But as we said here, guys, like we finished on, we have hyperinfiltrate injury. This injury will present at first with microalbuminuria, then it will progress to nephrotic syndrome, and finally it can cause renal failure. So we have hyaline deposition in the afferent and the afferent, so that will decrease the water and sodium going to the kidney, which will increase the RAS system, causing more vasoconstriction of the efferent. That will increase the hydrostatic pressure that back at the that like reflect back at the kidney. That will lead to the glomerulosclerosis, the Kimmelstein-Wilson nodules, and also it will lead to hyperinfiltrate injury. That will present first as microalbuminuria, then progress to nephrotic, and then to renal failure. So here we said, guys, it present first with microalbuminuria. So we can detect this microalbuminuria early with something that is very, very important to detect early diabetic nephropathy by the urine dipstick. Exactly, the urine dipstick. So if we detected the nephrotic, the range, I think it was like from 3 to 3, but just spare yourself the details. So we can detect this microalbuminuria early with the urine dipstick. And if we detected it, how we are gonna treat it so that it doesn't progress to like more and more, exactly. Because our problem here, guys, was that this efferent was so narrow that caused the increased hydrostatic pressure, so we will need to vasodilate it, and this will happen through the ACE inhibitor and ARBs as well. Okay, so yeah, and this will vasodilate the efferent more, so the hydrostatic pressure will decrease. That will also decrease the GFR, and then it will bring everything back to normal. So in diabetes, we have hyaline deposition that will lead to thickening and narrowing of the blood vessel, the efferent and the efferent, but the efferent will be more vasoconstricted, so that will increase the hydrostatic pressure back to the kidney, increase the GFR, causing the Kimmelstein-Wilson nodules and also causing the hyperinfiltrate injury. It will start with microalbuminuria, then to nephrotic syndrome, then to renal failure. So we can detect it early when it's in the microalbuminuria stage by the urine dipstick. And if we detected it, we will treat it with the ACE inhibitor because it leads to vasodilation of the efferent. That's pretty much what happens in the diabetic nephropathy. So do you understand everything to this point, guys? Huh? Like quick overview about the nephrotic. Okay, so nephrotic syndrome. What we have in nephrotic syndrome, our symptoms was foamy frothy urine, generalized edema, hyperlipidemia, hypercholesterolemia. So right now I am in nephrotic syndrome. What I will be thinking, exactly. First of all, if it's just a child with nephrotic syndrome, so I am looking at the minimally changed disease due to the damage and the flattened food process of the podocytes. If it's an adult with heroin, African American, HIV, sickle cell, so this is the focal segmental glomerulosclerosis. What if it's a patient, a nephrotic syndrome with history of systemic lupus erythematosus, or hepatitis B, or a solid tumor, or NSAIDs, or penicillamine. All of those will lead me to the membranous nephropathy, and it's due to IgG against the phospholipase A receptor present on the podocytes. If it's a patient with history of hepatitis C and there is the tram track appearance, this will be the membranoproliferative glomerulonephritis. If this patient has amyloidosis or he has any risk factor of amyloid disease, so I will find the pink amyloid with the congruent stain, and it will appear as apple green perfringens under polarized right. If this patient is a diabetic patient with high hemoglobin A1C, so this is probably a diabetic nephropathy, and we will find the hyaline arteriosclerosis or hyaline deposition, and the chemical stain Wilson need used, which is stain positive with PAS and eosinophilic with H and E. So here we have the PAS stain, and in the amyloid we have the Congo red stain. And also we can detect the early microalbuminuria by the urine dipstick, and if we detect it, we will treat it with the ACE inhibitor. So that's pretty much everything that we need to know about the nephritic and nephrotic. So if everything clear up to this point, guys? Because now I want to make sure that you got all what we have said. So we will practice, and the best way to practice is for sure our amazing QBank, which is Synapse. So here, and yeah, we have this amazing feature here, which is like the collection. So let me search for the renal. Okay, so yeah, this picture is really good, guys. Like as we did right now, we studied the nephritic and nephrotic. So I want to test myself at this topic. So I just go to the collection section and the subject, and here is it, the glomerular disease. So I can practice on this topic. So okay, first of all, I will hide all the answers. Okay, I will hide all the answers because when we solve these questions of nephritic and nephrotic, I want you to follow a certain pattern. We will read it. Whether the question is asking about, don't like don't rely on what's the question asking about. I want you, every question we read together, I want you to tell me first of all whether it's nephritic or nephrotic. Chill, guys, chill. I didn't read it already. So yeah, I I want you to tell me at first whether it's nephritic or nephrotic slash the diagnosis, like the cause, whether it's IgA or what, and slash like what made you, or what was in the history, or what was the risk factor that made you tell that this is this type or this certain type. And after we determine all those three things, we will go and proceed to see what the question is asking about. So you already read this question, but okay, okay. So yeah, but I will let me take a break. Okay, so I will read it because so if we have some people who are slow at reading it, we will read it. Okay, so we have a 7-year-old boy. He came to the physician by his mother because of 2-day history of dark cola-colored urine and swelling around his eyes. His mother notes that he has been less active than usual and complained of mild headache this morning. Approximately 3 weeks ago, the patient had several honey-colored crust sores in his chin that resolved with a topical ointment. On physical examination, the temperature, blah 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 blah. There is 1 plus bilateral periorbital edema and hyperpigmented scars, plus 2 protein, and plus 3 blood. The C4, the C3 is normal. And okay, so like I normally I wouldn't read all the question. I will just like when I read the first 2 lines and yeah, this is the case of nephritic or nephrotic syndrome. I will just take a quick look at the lab. Yeah, here I have low complement, so I just diagnosed it. So as Dr. Sumaya said, nephritic acute post-surgical glomerulonephritis, a child with impetigo, 3 weeks, the 3 weeks latent period, the low complement level. So this all lead to the acute post-streptococcal glomerulonephritis. Okay, now answer the question. What will be our choice here? Exactly, Dr. David. Exactly. So our answer here will be the glomerular deposition of immune complex and complement, because as we said, the acute post-streptococcal glomerulonephritis is type 3 hypersensitivity, which is due to immune complex deposition. But now let's have a look at the other choices as well. A is referring to antiglomerular basement membrane antibody deposition. Is referring to what? Exact. Dr. David, the good pastor syndrome. What about B, the deposition of IgA containing immune complex, exactly the Berger disease or the IgA nephropathy? What about D, mutation in the gene encoding the alpha 5 chain, the Alport syndrome, exactly. And finally, E, the T cell mediated cytokine injury to glomerular podocytes. This is the minimal change. As we said, it is due to hyperresponsiveness of the immune system, so there will be T cell mediated damage to the podocytes. Okay, let's move to the next one. Okay, yeah, we have, as we said, we will just read the first. We have the 25-year-old male come to the physician because of 3-day history of dark cola colored urine. So normally in the exam, I will just read this part and have a quick look at the labs, and I will solve the question. Here I have a tea-colored urine with the complement level is normal. So in my mind, I am saying this is uh, the IgA nephropathy. But let's read all the question to also figure out the other associated things. He reports no pain with urination, and as I said, I want you to tell me nephritic or nephrotic, the disease, and why is that? You are just skipping my pattern, guys. Tell me if at first it is nephritic or nephrotic, the disease, and why is that? So we have, he mentions that he has a runny nose, sore throat, and mild cough that began yesterday. He recalls having two similar episodes of dark urine, and this is the recurrent thing that we talked about, guys. As I said, IgA nephropathy, it will be like in a recurrent pattern. So you will find this history always in the, or not always, but you could find it most of the time in the case. Both occurring shortly after he developed a cold. He takes no medication. His blood pressure is 144 and his pulse, etc. We have the C3 complement is normal. The urine color is we have +1 protein. As I said, we can have mild proteinuria in nephrotic syndrome as well. The proteinuria is not exclusive for nephrotic, but it won't be the predominant. It will be mild. And most importantly, we have the 20 to 30 RBCs. So that means that we have a hematuria. As we said, nephrotic syndrome, a child with um a small latent period like 2 3 days that begins yesterday, so it's happening concurrently with the disease, and we have the normal C3, so this all lead us to the IgA nephropathy, and of course the histopathological pattern will be the mesangial proliferation. But let's see our choices. Yeah, okay, let me first okay, yeah, what's your answer here, guys? Exactly, it will be C. So immune complex deposition, mainly the IgA complex in the glomerular mesangium. But let's also have a look at the other choices. A is standing for antiglomerular basement membrane, is, as we said, the Goodbuster syndrome. B, the genetic defect, as we said, is the Alport. The subepithelial humps, which contains IgG, IgM, and C3 is, yeah, exactly, it will be the no, the subepithelial humps, Dr. Sumaya. It's not subendothelial. Yeah, the subepithelial. So the subepithelial humps is for the post-streptococcal glomerulonephritis. Exactly, Dr. David, Dr. Kanika. Brilliant, guys. And finally, the T-cell mediated injury, as we said, is the minimal change disease. Let's move to the next one. No, this one isn't with us. Okay, yeah. So this one, I will also hide the choices. I don't care about what the question is asking about. All I want is tell me it's nephritic or nephrotic, what type of disease, and why you said that. So here we have a 5-year-old boy is brought to the emergency department with high fever, productive cough, and right-sided chest pain that worsened with deep breathing. He was diagnosed with a renal condition characterized by generalized edema and began treatment with steroid. So, a quick look, as you did, guys, we have a child with edema, and also here we have hypercholesterolemia. So this is nephrotic syndrome. Okay, let's continue. Blood pressure is okay, the respiration, the oxygen, and we have the lung auscultation revealed decreased breath sounds and crackles over the right lower lobe, and there is pitting, edema, and the laboratory studies are as follow. We have the +4 protein, the blood, and we have the fatty acid. So this child, just a child with nephrotic syndrome, this is minimal change disease. But now let's see what the question is asking here. We have a chest radiograph of dense consolidation in the right lower lobe. The sputum gram stain reveals numerous neutrophils. Which of the following processes is most likely cause of this patient's increased susceptibility to the recurrent infection? I will show you the answers. Yeah, pick your answer, guys. Exactly, Dr. David. Exactly, Dr. Nidaris. So it will be a urinary loss of immunoglobulin. Exactly. So as you said, this is a minimally changed disease. Exactly. So it appear normal glomeruli in the light microscopy, and we have the electron microscopy, the flattened podocytes. Okay, let's move to the next one. I will repeat, I don't want the question answer. I want it's nephritic or nephrotic and the disease. Okay, so we have a 5-year-old boy by his parents because of a 4-day history of puffy eyes and swollen ankles. His mother notes that his urine has appeared frothy over the same period. So before I complete, puffy eyes, frothy urine, I am talking about nephrotic syndrome. Okay, he had a mild upper respiratory infection that resolved 1 week ago, but he has no other significant medical history. So we have a recent infection from 1 week ago. Physical examination shows significant preorbital edema. The edema, okay, we talked about it. His blood pressure, okay. The sodium, the potassium, the albumin, total cholesterol. His also I have hypercholesterolemia that will boost our my diagnosis to nephrotic syndrome, and we have the +4 protein, no blood, which if the following pathophysiologic process is most likely cause of this patient's condition. Exactly, we have a nephritic syndrome in just a child. Most of the time, it will be minimally changed disease. But let's say that we have this case, guys, like the same case, a recent infection from 1 week ago, but it's like nephritic syndrome. It's like hematuria and this stuff. So it will be exactly, the acute post-septicemic glomerulonephritis. So because it's like 1 or 2 weeks, but it will give you like 2 weeks or something. But just like to make sure that you already know the difference between the nephrotic and yeah, weeks, Dr. Sumaya, not days. Okay, so which of the following pathophysiologic process is most likely cause of this patient's condition? As you answered it, it will be D, due to the loss of the glomerular polyanion charge barrier. As we said, the negative charge is responsible for blocking the albumin from leaking. So if we lost the anions or the negative charge, there will be protein leakage. Now let's see also the other choices. The subepithelial immune complex with spike and dome. This is exactly Dr. Suman, the membranous. What about the exactly Dr. David? So what about the disruption of the glomerular basement membrane? Type 4 collagen. This will be exactly. Here it didn't like didn't specify whether it's due a mutation or it's antibody, but yeah, it will be like Albert or Goodbuster. But we already know the difference between the two. Okay, the linear deposition. Yeah, here this one is the Goodbuster syndrome, the linear deposition of against the glomerular basement membrane. So this is the Goodbuster syndrome, and fine. This is our answer. The segmental sclerosis in some glomeruli, which is exactly. So it's segmental, so it's focal segmental, and it's also in some glomeruli, so that's why it's focal. Let's see if we can have any picture here. That's good. Uh-huh. Yeah, we can look at this picture later, no problem. Okay, so let's see this question. The same thing I want is it's nephrotic, and the disease, and why is that? So we have a 24-year-old man come to the emergency because of 4-day history of shortness of breath and coughing of blood. He also reports that his urine appeared dark and tea-colored urine. So with this just two-line, guys, I already diagnosed it. What about you? Okay, nephritic, and it will be the Godbuster syndrome, exactly due to the coughing of blood. So we have nephritic and extrarenal symptoms, which is hemoptysis. So I am talking about the Godbuster syndrome. Okay, I think there is nothing here more. There is no mucosal ulceration, sinus. Yeah, and the labs. Yeah, we have the RBCs in the urine. Antibodies, okay, let's see our answer. I want you the answers. Autoantibodies against which of the following are most likely the cause of this patient condition? So the Goodbuster syndrome is 2, 3, 4. Type 2 hypersensitivities, so which means that the antibodies against the type 3 alpha 3 chains of type 4 collagen. So our answer here will be A. Okay, let's look at the next one. The same pattern. A 5-year-old boy brought to the physician by his parents because of 4-day history of swelling around his eyes. His parents note that the symptoms began shortly after he recovered from a mild cold characterized by a runny nose and cough. He has no significant past medical history. His physical examination showed periorbital edema at the periorbital region, and we have the albumin is low. The total cholesterol is high, so this is nephrotic syndrome. Okay, and we have a 5-year-old child. So it's just nephrotic syndrome in a child with a recent infection. So this will be the minimally changed disease. Pick your answer. Exactly. So here it's asking about the light microscopy of the renal biopsy, and as we said, no, you all got it wrong, guys. Focus, guys. It's the light microscopy, not the electron microscopy. As we said, the light microscopy, it's just minimally changed disease, so it will be normal appearing glomuli. We need to differentiate between these two guys. But the electron microscopy, if we zoomed in more, it will be the effacement of the food process. So don't get tricky by this thing. So what about the crescentic formation in the Bowman capsule or in the Bowman space? Exactly, this is the rapidly progressive glomerulonephritis. What about the subepithelial immune complex deposits with the spike and dome appearance? Exactly, it will be the membranous. What about the mesangial hypercellularity? Mesangial, so whenever we hear mesangial, it's IgA, exactly. Normal appearing is our answer. The segmental sclerosis is the focal segmental, exactly, and the effacement of the food podocyte, it's also for minimal change, but this will be in the electron microscopy, not the light microscopy. So it's very, very important to differentiate between the light and the electric in this case, guys. The light will be normal because it's just light microscopy. It doesn't have that zoom effect, while the electron microscopy will give you the details of the effacement of the podocytes food process. Let's move to the next one. We have a 48-year-old man comes to the physician because of 3-week history of progressive swelling of his ankles and puffiness around his eye. He was diagnosed with chronic hepatitis B and he hasn't been following up since then. The physical examination show 3 plus pitting edema at the thigh, and we have the albumin is low and total cholesterol, so it's nephrotic syndrome, and we have a history of chronic hepatitis B, so it will be membranous, not focal segmental. Dr. Sumaya, focal segmental was the HIV and the heroin, not hepatitis B. So the hepatitis B is for membranous nephropathy. A 24-hour urine collection shows a 4 by O. So, okay, which of the following is diagnosed, as we said, guys, it's the membranous nephropathy. The membranoproliferative, it will be like more to hepatitis C, and it will mention something about the tram truck appearance and the C3 nephritic factor. The focal segmental glomerulosclerosis, Dr. Samaya, it will mention the like it's African American, the HIV or the heroin, the obese, the sickle cell, all those stuff. The minimal change, it will be a child with a recent infection, and the AL amyloidosis, we will find there will be a history of systemic amyloidosis or something, and we will find the Congo red stain, the apple green perfringens of the amyloid. Okay, let's move to the next one. So we have a 21-year-old man come to the physician because of a 2-day history of dark tea-colored urine. He reports that 48 hours ago he developed a sore throat, runny nose. So 48 hours ago he developed a sore throat, runny nose, and low-grade fever, which currently resolved. And two similar episodes happened. So we have the recurrence pattern, we have the nephritic syndrome, we have the IgA. So as all of you said, guys, excellent, Dr. David, Dr. Nizaris, Dr. Kanika, Dr. Niha, brilliant guys. So it will be the nephritic Berger disease or the IgA nephropathy, and because we have the latent period are like 2 or 3 days. And also we'll find the complement level, which is the C3 will be normal, so this is nephritic. Here the question is asking which of the following is likely to be observed on the examination of this patient urine. Huh? It's easy one. Exactly. It's hematuria, so there will be erythrocyte casts. We made this question, so also we can know also the other types of casts. So the fatty casts can be present on the nephrotic syndrome, because as we said, nephrotic syndrome present with hyperlipidemia and hypercholesterolemia, so it can cause fatty casts, while the granular cast or the muddy brown cast with the acute tubular necrosis or the ATN. The white BC's cast, it will be associated with infection, so acute pyelonephritis or acute interstitial nephritis. And finally, the waxy casts are in the chronic renal failure. Okay, the final one, and I already I made sure that you all got this topic right, guys, and you are already perfecting it, so I have no worries. But yeah, let's do the final one. We have a 62-year-old man come to the physician because of a follow-up visit. He has 20-year history of type 2 diabetes mellitus. So here we are talking about diabetes mellitus, and he wasn't compliant. He has swelling of his feet and ankle. The blood pressure is high, and we have pitting edema. And we have, okay, the labs, the hemoglobin A1C is pretty much high, and we have the albumin is low. So renal biopsy is performed, light microscopy shows a diffuse thickening of the glomerular basement membrane, and as we said, the past positive stain or the eosinophilic nodular masses, which is called the Camden Wilson nodules, exactly. So this is nephrotic syndrome in a patient with diabetes, the hyaline deposition, the Camden Wilson nodules. So this is due to exactly the non-enzymatic glycation of the proteins. So this is the pathophysiology, and also we mentioned that it starts with microalbuminuria. So we can detect it by the urine dipstick, and we can treat it with the ACE inhibitor. So I guarantee you guys, if you understand this session, you won't need anything to solve any question in any QBank related to this topic. We pretty much discussed everything, every important high yield details. There will be some low yield stuff, but don't bother it. We just mentioned every high yield thing that you need to know, and it was really really glad having you guys. And yeah, if you feel like the urge that you need also more deep understanding, of course, not in this topic because this topic can't go much deeper and than that, but if you need like more understanding of any other topics, if you need anything during your preparation, you can try a 30-minute free session with either me or one of our amazing tutors. And if you feel like it's like it will offer you something, you can commit to our 1 hour packages that suits you. And if you are running short on time, also, I advise you with our 7-day USMLE crash course for step one. It really, really will cover 80% of the high yield topics that you will encounter in your exam. So it will be a great choice, and it's completely risk free. Like if you felt like this it's not for you or something, you can just take your money back, risk free, no question asked. And also, I want you to join our community. I will type the links in the chat, so also you can stay updated with everything we offer, and you can attend all our sessions. So this is our community, guys. You can join it, and you can feel free to ask uh, about anything at any time. Don't hesitate. It was really I was really, really glad to have you guys, and I hope that you have benefited from this session. And yeah, so yeah, goodbye and see you in other sessions. Goodbye, guys. Have a great day.